Good afternoon. Welcome to today's webinar, Protecting Seniors by Improving, Not Eroding Nursing Home Quality Standards. This is Lori Smetanka, and I'm the Executive Director of Consumer Voice. Just coming on to say hello and welcome this afternoon. Thank you for joining. We have a terrific panel of distinguished speakers that will be sharing presentations today with you that they provided at a recent Hill briefing, which you'll hear a little bit more about, and we thought that it would be beneficial for our membership as well as our broader network to hear these presentations and have an opportunity to ask questions of the presenters. We are going to be recording today's webinar, and the recording and materials will be made available afterwards. In the control panel for today's webinar, you'll see handouts that include some additional information about the topic that we'll be covering today, and we'll also make the PowerPoint available. As I mentioned, the webinar will be recorded and the information will be posted. All of the listeners will be on mute during the presentations. There will be an opportunity for questions at the end, and on your control panel, again, there is a space for you to ask questions, so please type them in there, and we will get to as many as we possibly can at the end of the presentation. And with that, I'm going to turn things over to Robin Grant, our Director of Public Policy and Advocacy.
Thank you, Lori. I know that I speak for all the presenters when I say that we are really pleased to have this opportunity to give all of you the briefing that we gave to Hill staff on June 4th. So I want to introduce the amazing group of experts that are speaking today. You definitely have the A-team, there's no question. So you will hear from Janet Wells, who is a consultant with California Advocates for Nursing Home Reform, and I will add, former public policy director at Consumer Voice. Richard Mollett, who's the executive director of the Long-Term Care Community Coalition. Toby Edelman, a senior policy attorney with the Center for Medicare Advocacy, and Charlene Harrington, who is professor at the University of California, San Francisco. So the reason for the original briefing that we did on the Hill was because as advocates, we have all become extremely concerned about the dangers that nursing home residents are facing right now. I think of it as a triple threat. There are delays, there's the rollback of nursing home regs we're worried about, and weakened enforcement. So our speakers will talk about these threats, but I want to just say a few words to make sure that everybody has some initial background. So the triple threat, in terms of delays, I think you all know that CMS has delayed for 18 months full enforcement of 8 key phase 2 regulations, many of which are really important residents. Second threat is the dismantling and undermining of CMS's own nursing home rules. You know, despite the fact that there were major revisions that were just made to the federal nursing home regs and released in October 2016, CMS is working to change these rules in order to reduce the burden on nursing home providers. So it's already issued a proposed rule to eliminate a ban on forced pre-dispute arbitration. That was in the rules that came out in 2016. CMS has asked for public feedback on whether to eliminate or modify certain requirements. And worst of all, from our opinion, it is announced it is going to release a proposed rule supposedly this June. So that is a huge concern. And then the third threat is also an enormous concern, which is weakening enforcement. I will say that this is a particular concern because many advocates believe that enforcement has actually been weak for decades. So weakening of an already weak system is particularly concerning. The primary focus of our concern is what's happening with CMPs, although there are other things that Toby, I know, will mention later on. But, as I think you all know, I mean, CMPs are really one of the most valuable enforcement tools we have, which is exactly why the nursing home industry has put such pressure on CMS and Congress, too, to get CMP policies changed. So there are changes that have already been made, and we really think that the net result is going to be less frequent and lower fines. So all very, very disturbing. So the purpose of that June 4th briefing, and actually of today's briefing too, is to examine those dangers that are faced by nursing home residents, and then to look at some possible measures to try to improve quality and resident protections in nursing homes. So next slide. So here's the agenda, just very, very quickly. After I finish the opening, you'll hear from Janet, who's going to give you, share a resident story with you, and talk about some background on the nursing home reform law and the Affordable Care Act as it pertains to nursing homes. Richard will then talk about nursing home quality, oversight, and staffing, followed by Toby, who will discuss enforcement of the nursing home standards, as well as the federal and state role in ensuring competent, financially sound owners and managers. After Toby, Charlene will talk about nursing home and financial accountability. We'll then end with some policy recommendations and suggestions for action, and then give you some time for questions. So briefly, as Lori said, your lines are muted. Feel free to type your questions into the chat box during the presentation, but there will also be time at the end. Next slide. And with that, I'm going to turn the webinar over to Janet.
Thank you, Robin, and good afternoon. When we did this presentation for congressional staff, we were urged to begin the presentation with a real case history, a story that would illustrate what happened to a real person who suffered from neglect and bad care in a nursing home. The saying that a picture is worth 1,000 words is absolutely true in nursing home cases. These are eye-opening about why regulations are not unnecessary and onerous, which is what the American Health Care Association has called them. I know you have many stories you can tell to your legislators and the media from your personal experiences as family members or advocates. We use the case of Rebecca Zini, a Georgia resident whose death was attracting international attention after her family's lawsuit against the facility was reported by an Atlanta TV station, The Washington Post, and other media, not only in the United States, but in some foreign countries. The story gained traction because Rebecca Zini's death from scabies was horrific, described by her family's lawyers as eaten alive by parasites. Photographs of her injuries, which the TV station used with her family's encouragement, were nearly impossible to look at. We chose to use these before pictures. The next slide. Mrs. Zini's story has elements that are helpful to explain why we oppose the weakening of the nursing home regulations and enforcement. We know her history. She was a modern-day woman in the 1940s and 1950s who worked for the Navy, was very beautiful and became a New York model. Then she became a mother and homemaker. When she was elderly, she developed Alzheimer's disease and lived in a nursing home for the 5 years before her death at age 93. Rebecca's, next slide, please. Rebecca Zini's nursing home had repeated outbreaks of scabies, which is a highly contagious disease that spreads through human contact and in which parasites burrow under the skin and lay eggs. Her family's lawsuit alleges that residents were not quarantined, staff who tracked the disease were not told to stay at home, Sheets of infected residents were washed with the rest of the laundry. Families weren't informed that there was a scabies outbreak and continued to visit and perhaps help spread the disease. Multiple residents and staff were infected during several scabies outbreaks around the time, in the couple of years surrounding the time that Mrs. Zini contracted it and died. Georgia health authorities took no apparent steps to investigate the cases of scabies or to order compliance with infection control measures. I'd like to add that the owner of this nursing home where Mrs. Zini, Mrs. Zini died is a former president of the American Healthcare Association and was one of 3 persons who were appointed by Senate Majority Leader Mitch McConnell to a National Commission on Long-Term Care, the future of long-term care. In June 2017, the owner was among a handful of industry leaders who met with the then Secretary of Health and Human Services to ask HHS to reduce the regulatory burden on providers. The next slide. In December 2017, Kaiser Health News did an investigation that found that infection lapses are rampant in nursing homes, but penalties are rare. 74% of nursing homes have been cited for infection control lapses, and yet only 1 in 75 facilities that were cited were cited for violations of a harm level that would actually lead to penalties. Your slide, next slide, please. The slides, which you're seeing a copy of, include links to articles about Mrs. Zini's case and also to the Kaiser article on infection control. Next slide, please. As background to the rest of the presentations, I'd like to touch briefly on the laws and regulations that are under attack by the administration today and why it is so important for us to defend the law and the regulations. As I'm sure you know, the 1987 Nursing Home Reform Law, OBRA 87, is the authority for nursing home regulation and enforcement. If you're relatively new to the field, you may not know how important the Consumer Voice and other organizations that are represented on this webinar were to the passage and implementation of OBRA. The passage of the bipartisan Nursing Home Reform Law would not have been accomplished without the leadership of the Consumer Voice, then known as the National Citizens Coalition for Nursing Home Reform, and other organizations that are represented here today. NCNR, the Consumer Voice, organized the Campaign for Quality Care Coalition, which worked tirelessly for more than a year to achieve a consensus among consumers, nursing home providers, and other stakeholders, the healthcare and social work professions, for example, and also labor unions, on legislative language. We reached a pretty broad consensus on legislative language. And after the law was passed, we continued to meet together for years to reach an understanding and agreement on regulatory provisions. We were the primary supporters of the nursing home transparency provisions in the Affordable Care Act in 2010, which included mandatory reporting of suspected crimes, reporting of ownership data on Nursing Home Compare, and the recently implemented reporting of nurse staffing based on auditable payroll records and as a key component of the 5-star nursing home quality rating system. For more than 4 years, we worked with you to ensure that Obama administration revisions to the requirements of participation did not weaken existing protections, but did improve regulations where the old requirements were not strong enough. Next slide. Now the Trump administration has announced that it is going to reform the nursing home reform requirements of participation to relieve the burden on providers, as you've heard. We must be united in speaking back to the administration and to CMS that we cannot be left out of this discussion and that we strongly disapprove of a process which excludes providers and, in fact, which takes work that was done over a long period of years and 4 intensive years in the revisions to the requirements that were published in 2016, that we oppose the process and the very action of repealing those regulations and starting over again. I'd like to turn it over now to Richard Mollett, with Executive Director of the Long-Term Care Community Coalition.
Thanks, Janet. And next slide, please. Thanks. No, this slide is good. So thanks very much, and thank you, Lori and Robin, for organizing this. Again, my name is Richard Mollett. I'm going to talk briefly about nursing home quality and oversight, which is, of course, quality assurance, and then also a bit about staffing. As Janet mentioned, the payroll-based journal staffing just came out for the first time publicly at the end of November, and it became part of Nursing Home Compare just a couple months ago at the end of April of this year. Next slide, please. Thanks. So as both Janet and Robin said, the nursing home reform law continues to be a very important protection for nursing home residents, and it came on the after there was significant advocacy, and that significant advocacy was necessary because there were truly scandalous conditions. And I remember going to visit my great-grandmother in a nursing home, and it was a pretty crummy place, and her existence was pretty crummy. As a result of the reform law, there have been some, very significant changes and improvements over the years. However, as I'll talk about next, and as sure you all know, a lot more needs to be done to continue to improve care and to continue to improve accountability for resident care, quality of life, and for meeting the standards. And before we move on, I just want to say, if you note at the bottom of the slide, I think in a nutshell, essentially, it is that too often it's buyer beware for nursing home residents and families. And that shouldn't be the case, and that's certainly not what the reform law requires. Next slide, please. Thanks. So what I did for the congressional staffers, and what I'll do for you here is just put together some highlights of things that are important to us, and I think that they're important to us because they're clear indicators that there are still serious problems. And one of the most remarkable studies, I think, that came out in the last couple of years is this Department of Health and Human Services Office of Inspector General report on adverse events in skilled nursing facilities. And the report was for 2014. They found, as I noted here, that an astounding 1/3 of residents who go to a nursing home for short-term rehabilitative care, Medicare residents, were harmed with an average of about 2 weeks. Close to 60% of that harm was preventable and likely attributable to poor care. And I still remember when I first read this report how shocked I was for a number of reasons. I mean, we do know, as both Janet and Robin have said before, and as you surely all know, that serious problems persist in nursing homes. But these are people who are coming into nursing homes for rehabilitative services. So everyone, of course, deserves and nursing homes are paid to provide appropriate care and appropriate services for every single resident that they take in, whether it be Medicare, Medicaid, private pay, etc. It does not matter. The law requires that every single person get the care and the services he or she needs to, as I'm sure you've heard before, attain and maintain his or her highest practicable well-being. But what was most astonishing here is, well, a few things. One is that 1/3 of these people were harmed within, again, 15.5 days, about 2 weeks of entering a facility. That, interestingly and importantly, the Medicare beneficiaries, the rates for Medicare are extremely high. The profits for Medicare are in the double digits and have been in the double digits for close to 20 years. But Medicare rates can be $400, $600, $700, $800 or more per day per individual to provide care. So this belies the nursing home industry's argument that they do not get paid enough money to provide good care, to hire enough staff, etc., because 1/3 of these residents were harmed. And lastly, before we move on, I remember when I presented this to our coalition here in New York, and one of my board members who used to be a nurse in a nursing home said, when I talked about this, those are the people who can speak. Those are the people who are aware generally of what medications they're supposed to be getting, of when they're supposed to be getting services, if someone forgot to provide occupational therapy to them, if there's something wrong with the pills they're receiving, et cetera, et cetera, et cetera. All those things, and these people were still harmed at this rate. And one thing that we, the groups that are talking today, have called for ever since 2014 is for the Inspector General to do a similar study on Medicaid residents, the people who are there for long-term care, because we can only imagine what their experience is and what those data would show. Next slide, please. So we did a study in 2015, which I think is also valuable, and we're actually going to be updating this study in the coming months this year. But what we wanted to do is look and see how what are the effects of state enforcement? What are the are there strengths? Are there weaknesses that we could identify? And most importantly, what I wanted to do was to focus on the resident level rather than on the facility level, because as I'm sure you've all heard over and over again, the reform law is special because the reform law focuses on the individual. It does not focus on the facility. It focuses on the facility providing the care and services, again, to meet every resident's highest practicable well-being through services, through care, etc. So too often, studies look at what the rates are, what the pressure ulcer rates are per facility, what drugging rates are per facility, staffing, et cetera, all on a facility level. What I wanted to do, and what we did here, was take it down to a resident level. Next slide, please. So we looked at three criteria that I thought were important. One was pressure ulcers, the other was antipsychotic drugging, and the third was staffing. What I wanted to do is take three indicators that we knew were important indicators of quality care and see what is going on. As I note here on pressure ulcers, I quote, the CDC, Centers for Disease Control, and a clinical journal, which is from our report, because I'm not a practitioner. I'm not a clinical practitioner, but I know how to read and I know how to, to figure out what is going on. Clearly, as those of us who have been family members and those of us who are advocates, know, pressure ulcers are serious conditions. What the clinical journal said and what the CDC said was that in the vast majority of cases, with appropriate care and appropriate monitoring, pressure ulcers can be minimized or avoided altogether. Nevertheless, what we found was that 7.5% of residents, that's over 95,000 individuals today in 2018, have unhealed pressure ulcers. This is based on federal data. Even though pressure ulcers, according to the experts, are largely preventable, states cite nursing homes the equivalent of less than 3% of the time that a resident has a pressure ulcer. And then even when states do cite the facility for inadequate pressure ulcer care or prevention, so they've made the connection between someone getting a pressure ulcer and inadequate or inappropriate pressure ulcer care, they only identify this as having caused harm to a resident approximately 25% of the time. And I just thought that, and I still think that that is completely outrageous. I mean, if you can't connect as a surveyor that a pressure ulcer, a wound, is harm, then there's something seriously wrong with our system. Next slide, please. As I said before, the second criteria that we looked at was antipsychotic drugging. Now, as many of you know, this is an issue that has been of significant concern to all advocates. About in 2011, the Inspector General did a study and found that in regard to, as I put here in bullet 3, in regard to the over-medication of nursing home patients, government, taxpayers, nursing home residents, as well as their families and caregivers should be outraged and seek solutions. And those of us on the who are presenting today met with then Administrator Donald Berwick, and he agreed with us. And he said that CMS was going to take action. Unfortunately, Dr. Berwick left CMS, and action has been really slow. So in 2012, there were about 26% of nursing home residents were receiving antipsychotic drugs. Now, currently, it's about 20% of residents. However, and again, I'm not a clinician, but I looked this up and I put together the numbers. Less than 2% of the population will ever have a diagnosis for which CMS risk adjusts for potentially appropriate use of antipsychotic drugs. As we note here, less than 1/3 of 1% is the average state citation rate for inappropriate drug use. That was 2015. And again, we're going to be updating this study this year. And only 2% of those citations are identified as causing any resident harm. And just before we move on, the one reason why we see identification of resident harm as so important is because a facility almost never faces any penalty unless harm is identified, meaning that there's no fine, there's no denial of payments, etc. And the message, therefore, is if you're not being penalized when you're cited, you're being essentially told you can go on with that poor practice. It's not going to affect your reimbursement. It's not going to affect your payments from us, and you're not going to face any penalty. Next slide, please. Lastly, we looked at staffing, and we all know that staffing is the most important, or one of the most, if not the most important indicators of a nursing home's quality, of safety, et cetera. It's, I think, the biggest complaint. It's certainly behind virtually all of the deficiencies that I see, the health deficiencies that I look at. Here you can see in the second bullet, the annual rate of staffing deficiencies per resident is infinitesimal. We found 0.036%. And then less than 5% of those staffing deficiencies, when it is cited, are identified as having caused resident harm. Next slide, please. Lastly, we put together some data a couple of years ago. One organization with which we have worked, Voices for Quality Care in Maryland and Virginia, they noticed that a number of nursing homes that they were going into seemed to have the same problems year after year after year. And as a result of that, we were able, working together, to get someone to compute the citations that appear on Nursing Home Compare to identify which facilities had the same citations for the same regulatory standards year after year after year. And specifically, what the program does is it looks to see how many facilities have 3 or more citations for the same relation for the 3 years that are on Nursing Home Compare at any time. And we did an analysis of these data when we published it last year in 2017, and we found that 42% of nursing homes nationwide have what we call chronic deficiencies, meaning they have the same deficiency year after year after year. And this gets, of course, to a serious problem that we all know about, but maybe don't realize as specifically that nursing homes are not being forced to correct or to appropriately correct problems when they have them, and therefore the problems reoccur. Next slide, please. So I'm going to move on quickly to staffing data. As I mentioned, the second part of the presentation gets back to what Janet had spoken about before, that as of November 2017, CMS finally fulfilled a requirement from the 2010 Affordable Care Act, so-called Obamacare, and they required facilities to report to CMS auditable payroll-based data. So the requirement was finally put into effect in 2016, and CMS took about a year to clean up the data. And in November of last year, they started publishing it on their underlying website. And as I mentioned before, at the end of April of this year, they started including it on Nursing Home Compare. So what did the data show? You can see here on the left-hand side, they show who's been assigned to provide care staff versus administrative staff. They show staffing on weekdays and weekends. They show the RN staffing. And also they'll be showing in the future whether staff is on the payroll of the nursing home or whether they are contract staff. And that's important And we just learned a couple of days ago that they'll be coming out with that in the future. But right now, those data are not being published. Right now, what do the data indicate on the right-hand side? We found that 82% of nursing homes report total direct care staffing hours at 4 hours per resident per day or less. A 2001 study that CMS did, they found that 4.1 hours of direct care staff time is typically needed to meet a resident's clinical needs. And actually now it is much higher than that because clinical needs have increased as resident acuity has increased. Secondly, we found that 30% of nursing homes report total direct care staffing of 3 hours per resident day or less. A really, really low number. Next slide, please. We looked at RN staffing in particular because RN staffing is so closely correlated to quality care. I just want to mention that the data that I'm speaking about here from our analysis, this is based upon the staffing that are assigned to provide care. So what CMS does is they lump all the staff together, whether it's administrative staff or care staff. What we've been doing and what I'm talking about here are the staff that facilities report are on the floor, staff that they are saying are assigned to provide care. And what we've done, and I think I'll leave with our website at the end, I think it's on the last slide, that it will show, we show for every single quarter what the staffing is for every single nursing home based upon the direct care staffing data. So you can look up the hours per resident day for any nursing home in your state for the most recent quarter published by CMS. And the most recent quarter now is 2017, the last quarter. But RN staffing was a particular concern. We found that 70% of nursing homes report RN care staff of a half hour a day or less. That 2001 study indicated 0.55 to 0.75 hours is typically needed to meet a resident's needs. Again, that number is actually higher now. CMS itself has stated that it's concerned with recurring instances or aberrant patterns of days with no RN on site. They found 6% of facilities have 7 or more days in a quarter where no hours for RNs were reported, and that 80% of all these days with no RN hours were weekend days, which is what everyone knows. Everyone who's an advocate, everyone who's a family member, I would say, everyone who's an ombudsman that I've ever spoken to knows that on the weekend, at night, things seem to be, and on holidays, staffing is really down. We found in our analysis that there are hundreds of nursing homes that have the equivalent of 0 hours of RN care staff time per resident per day, every day. Because with the data that I put together, those data are average for the quarter, and we found hundreds of nursing homes that had the equivalent of 0 hours of RN staff time. Lastly, we found that 25% of nursing homes, including many for-profit and not-for-profit facilities, were providing at least 0.55 hours of RN staff time. So it can be done. It's just that nursing homes too often are not doing it. And as I noted in the earlier slide, not being held accountable for having sufficient staff. Next slide, please. This is just a slide showing how we put together the data. And again, it's on our website. You can see at the bottom here, nursinghomes411.org. And you could sort it. You could search to see nursing homes. You can download the data for your state, and then you could search by nursing home. You can actually scroll up and down to see, or you can culminate the data, by average RN hours, average staffing hours, etc. Next slide, please. That's it. Thank you very much again. On the website, our website, nursinghomes411.org, we have a lot of resources and materials, but those data are up there. So please feel free to take them and use them any way you see fit. And I'm going to turn it over to Toby Edelman, Senior Policy Attorney for the Center for Medicare Advocacy. Thanks.
Thank you, Richard. Next slide, please. As we've been talking about the Nursing Home Reform Law, the law from 1987 governs everything about nursing homes. The requirements of participation, which Robin and Janet have said are up for grabs now in the Trump administration, the survey process, and the enforcement process. What happens if facilities are not properly implementing the law? What sanctions or remedies should be imposed against facilities that are found during the survey process not to be meeting requirements of participation, not providing residents with the care and services they need? We know that 3 factors make enforcement meaningful. First, sanctions or remedies have to be imposed quickly after noncompliance is found and identified, not years later. Secondly, fines that are imposed and actually collected need to be higher than the cost of complying in the first place. In other words, if it costs less for a facility not to have enough nursing staff on nights and weekends, as Richard has just demonstrated is quite common, then facilities may choose to accept a financial penalty if one is ever imposed as the cost of doing business. Small fines are just the cost of doing business. They have no deterrent effect whatsoever. Third, enforcement actions need to be public. If people are aware of problems at a facility, they may try not to place a family member or themselves in that facility. The Nursing Home Reform Law, which addressed the enforcement process, requires states and the federal government to have a broad range of remedies available. Civil money penalties, the key one, as Robin said, which can be imposed for each day of a deficiency. That's the per day civil money penalty. These accumulate over time. Or penalties that can be imposed as a one-time amount, so-called per instance penalties. CMPs are the most common penalties we hear about, but they're not paid until a facility's administrative appeal is concluded. The reform law authorizes other penalties that go into effect more quickly when the problem is first identified. These remedies include denial of payment for new admissions or for all admissions, temporary management, which means the state takes over the facility, at least for a while, tries to get it back into compliance, monitors, loss and termination, loss of authority to receive reimbursement under the Medicare and Medicaid programs. The law also explicitly requires enforcement agencies to impose more substantial remedies and higher fines if deficiencies are serious, if they're uncorrected, and if they're repeated over time. But the enforcement part of the law, as we've been saying, has always been the weakest link and the most seriously contested part of the reform law by the industry. Non-compliance with requirements are called deficiencies, and they're classified into one of 12 categories based on how serious the non-compliance is, from not harming residents at all to placing them in immediate jeopardy for serious or life-threatening harm, and how many people are affected, one, a few, or everyone in the facility. Next slide, please. Under the system as implemented, almost all deficiencies are called no harm, even when the residents suffer serious harm. The Center for Medicare Advocacy and the Long-Term Care Community Coalition, Richard's organization, have been publishing a monthly newsletter of so-called no harm deficiencies. So one example we recently reported was maggots identified in a resident's scrotum. No harm. Several years ago, the Center for Medicare Advocacy did a study of antipsychotic drug deficiencies in 6 states over a 2-year period. And almost everything was called no harm. In fact, 4 states never cited harm in any antipsychotic drug deficiency, no matter how many residents were harmed and how serious the harm. One example of a no harm deficiency was 3 residents out of a sample of 10 were given antipsychotic drugs. 1 resident got drugs for refusing medications, which of course is the resident's right to do. That resident fell 20 times. Another resident in that sample was given 2 antipsychotic drugs, both above the recommended daily dosage, and a 3rd antipsychotic drugs. No harm. Nationwide, more than 95% of deficiencies are called no harm. Only about 3 to 4% of deficiencies are called harm or immediate jeopardy. But the way the enforcement system has been implemented, enforcement is generally limited to the 3 to 4% of facilities that are cited with harm or immediate jeopardy. Next slide, please. As weak as this system has been, the Trump administration has rapidly made it considerably weaker. Just to backtrack to this slide, should have moved a little more quickly. I think when we see that only 3 to 4% of deficiencies are called serious enough to have sanctions and small penalties we know are the cost of doing business, it's really very hard to talk about burdensome regulations. It's practically as if nursing homes get to decide whether or not they want to comply. It's not really, the law is not enforced. Next slide, please. So as I started saying, the Trump administration is making a bad system considerably worse. A major change by the administration was making per instance CMPs the type of CMPs to use, the default, instead of per instance CMPs as they were under the Obama administration. And they've done this through sub-regulatory guidance. These are survey and certification letters that are addressed to state survey agencies, but there was no notice, no public comment. Here it is. One day, we have the Obama administration guidance from 2014. The next day, there's a July memorandum saying we're making per day CMPs the default. The effect of that is that the maximum per instance CMP is $20,965. Per day CMPs, of course, have no dollar limit. It could be that $20,000 times the number of days of noncompliance. So the shift is a significant one, moving to a per instance CMP. Next slide, please. You can see from the data that the shift has occurred. In 2016, during the Obama administration, per day CMPs were twice as common as per instance CMPs. In 2017, which included the change, the shift that the Trump administration made, we see that the per instance CMPs outpaced the per day CMPs. More per instance CMPs in 2017 than per day. And finally, in 2018, fiscal year 2018, we have data from October 1st, 2017 through May 7th. We see here that the per day CMPs were dwarfed by the per instance, twice as many per instance CMPs as per day CMPs. And with more than 7 months of the fiscal year completed, according to those data, we're on track to have many fewer CMPs of either type imposed. Now the amounts have gone up. You'll see that the average amount of the per instance CMP is higher, from 3,000 in fiscal year 2016 to 10,000 in fiscal year 2018. This is partly because federal law was changed to require an annual update to the amounts of the CMPs to reflect inflation adjustments. Next slide, please. So there have been a number of other changes that have been made, and these seem, I know, very much in the weeds, but they can have a very enormous impact on reducing fines that facilities may face. The administration says fines should not begin before the first day the survey begins, even though the federal regulations say very explicitly that fines start when the facility was first found to have violated the law and regulations, even when the violations began before the survey. Of course, facilities are required to follow the law 365 days a year, provide good care to people every day, not just when surveyors are present. But that's what the changes put in place by this administration do. They're intended to limit fines to the days of surveys, with very, very rare exceptions. There are other kinds of changes that seem very obscure, but are going to make a tremendous impact. And the entire purpose is reducing the fines and the enforcement actions for even the worst, most serious deficiencies. Just last week, last Friday, came at 4:45, they put out a new memorandum which also overturned another Obama-era enforcement document from July 2016. What this did was say we're going to limit mandatory CMPs for immediate jeopardy to deficiencies where there is serious injury, harm, impairment, or death. The regulations do not make that distinction. They do not require serious injury, harm, impairment, or death in order to cite immediate jeopardy and have a high penalty. And in fact, a number of the administrative appeals, the judges will say, you are just lucky, facility, that nobody died. This resident kept eloping. You had no system to protect the resident. All of the systems you had failed. The doors didn't alarm. Nothing happened. So it's just by chance and by pure luck that nobody died. What the Trump administration is saying, unless there is serious injury, harm, impairment, or death, we're not going to have mandatory CMPs. And they tell regional offices, this new guidance from last week, that when they select remedies, they should consider whether the compliance was a one-time mistake, a systemic concern, or an intentional action of disregard for resident health and safety. These are not the standards. Facilities act through their staff. A one-time mistake is a deficiency if a resident is affected. So again, all to reduce the kinds of penalties and the amounts of penalties and which facilities will have any kinds of penalties for providing bad care to residents. Next slide, please. So what I want to turn to now for the next couple of minutes is something that's very disturbing to us, and it's the tremendous upheaval in the nursing home industry that we have seen, especially in the last several months. When Medicare and Medicaid programs were enacted in 1965, most facilities were individually owned. They were for-profit, not-for-profit, or government-owned. The enormous infusion of public money from Medicare and Medicaid led to a shift to a for-profit industry. Over time, multi-state chains bought up these individual firms, and about a decade or 15 years ago, private equity firms bought many of these chains and started selling off the real estate to real estate investment trusts. Large chains in particular have multiple related owners that all get a piece of the reimbursement, but their multiple companies make it appear that the facility has no money or is losing money. Next slide. In the past couple of months, especially, the nursing home ownership and management have been very dramatically shifting and even crashing. Some of the real estate investment trusts have raised rents on the facilities, forcing some of those chains into bankruptcy. That's certainly true of the real estate investment trust that owned the property for Manor Care facilities. Some of the chains have decided to get out of the business entirely, and they've decided just to own the real estate and buildings and shifted the responsibility for running facilities to other owners who may not know how to run the facilities at all. Next slide, please. The most extreme example in the last several months is a New Jersey company called Skyline. Since 2015, this virtually unknown company, which the newspaper articles describe as operating from above a pizza parlor, bought 110 facilities in at least 6 states. But between the end of March and the end of April this year, Skyline stopped meeting payroll and stopped paying vendors at many of its facilities. And newspaper reports were saying that the facility had food only for a couple of days. It was a total crisis. Skyline had just collapsed, was going into bankruptcy, and the states were required to go into court to take over these facilities quickly in order to protect the residents and to make sure there was staff and food and supplies. Several problems are illustrated by this total collapse of Skyline. First of all, corporate owners are keeping the most profitable parts of the nursing home business for themselves, the real estate, and shifting responsibility for care to others. Second, the new owners may not know how to provide care at all. States are obviously left with a crisis, and in their haste to get out of the business of running facilities directly, they may give the facilities to owners who know nothing. One of the Skyline facilities in Pennsylvania, for example, was given to a new for-profit company that had formed days earlier, and the state was unable to tell the reporter who asked who was behind this new company. They didn't know. They just said, okay, you run it. A third concern is that many of these owners whose companies collapse may simply go on to start another corporation and repeat the bad practices. Our government agencies whose primary responsibility is protecting public health and safety either don't have the tools to deal with these problems or they don't use these tools effectively. A report last month by the California State Auditor found that the health department did not follow its own rules in approving applications for licensure. Also last month, a new Vermont law was passed, which recognizes the need for better oversight of facilities, especially financial issues and the responsibilities of the owners of the real estate. So we're very concerned about this issue. We are spending quite a bit of time about the upheaval in the nursing home industry and talking to some of the staff people on the Hill about what can be done to make this situation better. I believe that is my last slide, and maybe one more, but I think this is the end. Okay, there's the California audit and the Vermont law. So I think, next slide, please. I think we're ready to hear from Charlene now. Thank you very much.
Okay, thank you. I'm going to be talking about financial and accountability issues. So next slide. Nursing home expenditures have continued to be high, and spending is expected to increase to $192 billion in 2020, which is 5% of total U.S. expenditures. And who is paying for nursing home care? Well, 66% of total care is paid by Medicare, Medicaid, and other government sources. And the average nursing home receives about $10 million in revenues annually. Next slide. There's a myth that nursing home payments are not good enough. The Medicare Payment Advisory Commission reports that Medicare payments to nursing homes are too high, and it finds that the Medicare rates are more than adequate to provide quality care. So they recommended no increase for Medicare in 2018 and 19. And yet CMS continues to increase reimbursement rates for nursing homes. In 2018, CMS announced $850 million increase in reimbursement. Plus, nursing homes will receive about $2 billion in savings over the next 10 years. For-profit nursing homes also will reap a windfall from the tax reform law. And in fact, the stock prices for nursing homes have just recently gone up because of these rate increases. Next slide. There's a lack of financial accountability under the Medicare prospective payment system. This system pays higher rates based on facility self-reports of the acuity of residents, and this encourages the facilities to inflate their resident acuity so they get higher payments. Medicare does not audit resident acuity or financial cost reports. And because there are no specific minimum staffing standards, nursing homes are allowed to cut staffing levels and labor costs and to shift the money from care to profits. Next slide. So where does the nursing home money go? Surprisingly, only about 37% of nursing home revenues are spent on nursing care for residents. And 23% of revenues go for administration and profits, and 10% goes for property-related costs. Next slide. As mentioned, the nursing home profits are very high. Medicare profit margins have been over 10% for the past 17 years, and 25% of nursing homes had over 20% profit margins in 2016. The Medicare Payment Advisory Commission repeatedly has urged Congress to cut rates because of the high profits and concerns about excess therapy services. So overall profit margins are positive, but the financial reports of facilities do not show the hidden profits that nursing homes have. Next slide. Profit taking is hidden in related party transactions that siphon money from care and staffing. These hidden profits include facility leases to property companies that are owned separately by nursing home owners. It includes inflated administrative payments for management pharmacies, staffing, therapy, and other companies that are separately owned by owners. Also, excessive interest rates on loans made to the owners, and owners take withdrawals to pay themselves. The California State Auditor found a 66% increase in related party transactions over the past 3 years, and these exceeded over $1 billion in 2017. Next slide. As mentioned before, nursing homes make money on the real estate holdings. This is a slide from a long-term care properties company that announced recently over a 200% profit in the past 10 years. Next slide. One policy approach is to establish a minimum medical loss ratio for nursing homes. A medical loss ratio is the share of revenues that's spent on patient care as opposed to administration and profits. This was adopted for health plans under the Affordable Care Act of 2010 that saved billions of dollars by requiring health plans to return excess revenues to payers. Congress could adopt this by requiring that 80% of revenues must go for nursing care and limit the profits and administrative costs to 20%. Next slide. Finally, there are a number of policy options that could be taken, but there's certainly a clear need for greater nursing home financial accountability and limits on administration and profits. So now I'm going to turn things over to Robin, who's going to talk about policy.
Thank you so much, Charlene. Before I get started, I just want to announce that we're going to extend the webinar time a little bit so that we can get all the information in and still have time for some questions. So thank you for hopefully staying with us. So I think you can clearly see that we are certainly faced with significant problems and issues with nursing home care nationwide. But these problems are not insurmountable. So there are a number of concrete actions that all of you can take to help nursing home residents, and that's what we want to share with you today. So I'm going to give you a brief, very high-level overview of 4 specific recommendations, but in the materials that you got, you'll find a handout about these policy recommendations that goes into more detail. So there's more information available to you. Next slide. So the first recommendation I want to talk about is about pushing back against the rollback of regulations and enforcement. You know, how can you do that? First of all, you can tell both Health and Human Services Secretary Azar and Centers for Medicare and Medicaid Services, CMS, Administrator Seema Verma, to retain the regulations as they were issued in 2016 and not roll them back and not gut these critical requirements. Second, you can tell both of them to reverse those enforcement policies that weaken the system. Toby told you about a number of those policies that really are going to have quite an impact. Instead, what we want CMS to do is, you know, not roll things back, but to actually improve the enforcement system, which really needs to be so much stronger. And on the handout I talked about, as well as on the screen, I've identified just one improvement that could be made, and that relates to this terrible problem we have with deficiencies being under assigned scope and severity and found to be no harm. Next slide. So the second action you can do is, in addition to contacting Secretary Azar and CMS Administrator Verma yourself, you can contact your members of Congress and urge them to give the Secretary and CMS Administrator the same message. Our experience has been that it really sends a strong message when members of Congress contact CMS, because CMS does have to respond to those members of Congress, unlike, sadly, some of the constituents. But so this really could be helpful. So we're asking you to do these two actions. Next slide. And we're trying to make these actions as easy as possible. And perhaps the simplest way to do this is to write a letter. Write two separate letters, actually, that you can send by email or by snail mail. And in your handouts, there's one that's called "What You Can Do to Help Save Nursing Home Protections for Residents." So we give you some tips about what to put into that letter. And I can't urge you enough to take just a few minutes to contact the Department of Health and Human Services, the CMS, your members of Congress with this message. I want to tell you, CMS, HHS, and Congress, they have heard a lot from nursing home providers. Absolutely a lot. And unfortunately, too little from consumers and advocates. They need to hear about your experiences and your stories. So please share the other side of the story with these agencies and Congress. So those two recommendations are essentially about holding the line and advocating at the regulatory level. But there is more that can be done and actually needs to be done, and done legislatively, to proactively improve quality and resident protections. So the remaining three policy options that I want to cover all involve legislation. Next slide. Thank you. Okay, so the second recommendation is about financial stewardship. So this speaks directly to what Charlene was talking about. I mean, we believe that there needs to be financial stewardship of how nursing homes spend their money. From what I understand, when Charlene explains and covers her material, when I boil it down very, very simply, it comes down to federal government is giving billions of public dollars to nursing homes, letting them spend the money however they want, and not policing their reports about how they're spending government money. So the net result is that residents suffer because those tax dollars that are intended for their care are essentially being diverted, with much of it ending up in owners' pockets. So members of Congress can ensure that that doesn't happen, and that those funds are spent appropriately and responsibly by passing legislation that has three components. And these components correspond to the points that Charlene made so well. So the first component that we believe needs to be in legislation is audits of cost reports. Second component is transparency. We need that through detailed financial reporting, but also reporting that includes disclosing finances that go to the related party companies and owners, because that's more and more where money is going. And the third component is that we need limits on how much money in administrative costs a nursing home can claim, and above all, how much profit they can make from those public funds. And that's the idea that Charlene talked about as a medical loss ratio. So your role in this is you can help make that happen by educating your senators and your congressperson about this issue. and that there's a big need to address it, and that can be done through legislation. Next slide. So this recommendation corresponds to the issues that Toby was talking about related to owners and managers and corporations. You know, as Toby pointed out, these corporations that own facilities and then the management companies that are increasingly running them, they need to be financially sound and have a good track record. You know, it just makes no sense to allow corporations and management companies that are struggling financially or have a long history of poor care to buy or operate homes. And so residents, when that happens, residents are the victims of the buying and selling of homes, and that is just not acceptable. So what can you do? Well, again, you can talk to your members of Congress about how this problem impacts residents, and then urge them to protect residents by passing legislation that mandates, first, that CMS develop procedures to assess the financial stability of purchasers and managers and evaluate their provision of care. So in other words, let's make sure that they have the money to do this work and that they have a good track record. And then secondly, the legislation should mandate that states actually enforce those procedures. So that would certainly go a long way to improving the situation that we are now seeing kind of all around us. Next slide, please. And the fourth and final recommendation has to do with nursing home staffing. And I know that's an issue that all of us have been concerned about literally for decades. You heard the data that Richard provided about staffing levels. It's extremely troubling. The lack of enough staff to provide residents with the care they need when they need it in our office is the #1 complaint that we hear from residents and families. And I know we're not alone in hearing that complaint. I'm sure all of you who are advocates and hear it, and those of you who are family members or residents experience it. You know, we know that there's a relationship between staffing levels and quality of care. We've seen study after study that has shown this. So we know that that is a very strong relationship, and we know that residents suffer when staffing levels aren't adequate. So the question is always, why is this happening? You know, why is understaffing so prevalent? And there's certainly a number of reasons, but we believe that the major reason is that there's no required minimum staffing standard for nursing homes. And I know that all of you know this only too well. Unfortunately, Medicaid and or Medicare certified facilities simply have to have sufficient staff under the nursing home regulations to meet residents' needs. And as we all have seen, this provision is extremely vague and ambiguous. And because there is no specificity, that means that the decisions about staffing levels is left up to individual nursing homes. And then the result of that is that facilities often cut staffing absolutely to the bone in order to maximize profits. So staffing is the foundation of quality care. And we know and have advocated for years that one of the most important actions that Congress could take would be to pass legislation requiring minimum safe staffing. And a piece of really exciting news that we are really thrilled to tell you is that such legislation is actually in the works. Congresswoman Schakowsky and her staff have begun the process of drafting a bill. And when it's introduced, we hope that we can count on each and every one of you to work to get the support of your federal legislators, because this can literally make all the difference in the world. Next slide. So I just want to close out my part by saying that our primary focus right now has to be defending the regulatory enforcement system. The regulations and enforcement are the foundation of quality care and quality of life for residents. And if they're significantly weakened, it's the residents who are going to suffer. So we've given you information about writing a letter to HHS, CMS, and your members of Congress. So please, maybe even right after this webinar, take a few moments to send an email or a hard copy letter. And as Janet noted with the story that she shared about Rebecca Zini, stories can have a real impact as well. So share your story, share stories of the residents you know. I can't stress how much your advocacy on this issue matters. You know, it's easy sometimes to think, okay, I'm too busy. I know somebody else will step up to the plate and advocate, and so I'm going to pass on this one. This is not one of those times. This is not a time when you can leave it to others to advocate. You know, we have to join forces. We have to take action and fight as if residents' lives depended on it, because, you know, those lives do depend on it. And we have to join together and advocate, because we know we are so much stronger and more powerful together. And because, quite frankly, if we don't speak up for residents, who will? And with that, next slide. We'll open things up for questions, and Lori has been monitoring them throughout the presentation, and this is also an opportunity for you to submit a question if you have not yet done so. Lori?
Thanks, Robin, and thanks to all of you for excellent presentations and terrific information that you shared that I think the listeners today are going to be able to take back and use in their advocacy. And there have been a number of comments about the quality of the presentations today. So thank you all for that. We do have a couple questions, and let's just stay on for a couple more minutes, if you don't mind, and just try to answer a couple of them. So one, which came in while Richard was giving his presentation, and so Richard, certainly you can answer it, but any others who want to answer it as well can, is why do you think states are so remiss in recognizing harm to residents and citing these incidents that are happening?
Thanks, Lori, and thanks for the question. I think that there's a number of factors, but I think it really comes down to the tremendous political influence that the provider industry has, both in Washington, D.C. and in the state capitol. I think one thing that I think has been a theme throughout the presentation is that providers are making a lot of money, and there's a lot of money to be had in various ways through nursing home care, from the underlying real estate to the providing services, et cetera. And as a result, there are lobbyists, again, in every state capital and in Washington, that are actively working to lessen the accountability and putting pressure on the on state survey agencies.
Mm-hmm.
Thanks.
Lori, can I say something about that too?
Yeah, please. Go ahead, Toby.
Oh yeah, thank you. When we at the Center for Medicare Advocacy did the study of antipsychotic drug deficiencies, one part was to send a questionnaire to surveyors in those 6 states, and we had 2 or 3 additional states that asked for their surveyors to get the questionnaire as well. We had over 400 responses, and Dean Lerner and I went through every single response repeatedly. We actually wrote a lot of open-ended questions, which you're told never to do in a survey because you'll go crazy. But we really wanted to know what the surveyors were thinking. So we have a very long report about that and an abbreviated version. There are a lot of reasons. Absolutely, many surveyors said exactly what Richard said. Some surveyors were explaining their problems with, if they were citing an antipsychotic drug deficiency, physician who had prescribed it would say, you know, what medical school did you go to? Who are you? Who are you to challenge me? So there's a lot of intimidation from the facilities, from the doctors, to the extent they ever heard from them. There's a lot of pressure to get surveys done, as they have to get the annual survey done on time, or the state can be penalized financially. So surveyors sort of rush through the survey because we know a number of the state agencies are understaffed, very huge vacancies. So there's a whole range of problems and reasons why surveyors don't do as good a job as we would like. And I had to share that report. It was very interesting to read what they had to say.
Thanks, Toby, for adding that important information. There was a question about, and I think a couple of you have addressed this in some fashion, but if anyone wants to add more, but what can be done to counter the money and power and co-opting that seems to occur with some of the state and national elected officials?
This is Janet. I think, again, getting back to stories, and again, I can't emphasize how much impact that has on members of Congress. If you have photographs, documentation, but our family members who will speak to your members of Congress, if you are in a position to invite your representatives to tour nursing homes with you, the nursing industry does that very effectively. They pick out a good facility and have everything looking bright and nice, and happy residents and staff when the congressman comes in. It's very eye-opening to an official to see a more realistic view of nursing homes and inactivity, the bad smells, the lack of staff, the lack of good interaction between staff and residents. So strongly urge you to get a real clear message to your members of Congress. It's much better if you do it in your district and in your state than if we're doing it here. And we do our best, but you're the ones who vote and you're the ones who have an influence on your community. So I really hope that you will be doing that in the next few months. We don't know when these changes to the regulations are coming out. They're supposed to come out in June. We don't really know what the real schedule is, but it could happen soon. And so you really need to get out there with a message.
So this is Robin. I just want to echo what Janet said, and to say, the industry has money. There's absolutely no question about it, but we have numbers. But unfortunately, our legislators are not hearing from us enough. And so just getting engaged. Legislators track when they hear from constituents. And I think a lot of people feel that, oh, what difference does it make? I'm just one person. If it's not going to do any good. That is absolutely not the truth. They follow and see where their constituents are. If there's a bill or something, they're tracking the numbers of people that are calling in saying yes or no, or emails. You can make a difference. So I think a big part of this is speaking up. And it doesn't have to be complicated. If you can take somebody, out on a visit or share a story, that's great. But sometimes just sending a quick message can make a difference. And we need that to be done by the hundreds and thousands and billions.
And get to know your local reporters too, and be sure they're educated about conditions and that they're writing about problems. And nothing's more gratifying than to walk into a powerful member of Congress's office here in Washington and see a local story lying on his desk about a nursing home problem. That member noticed it. He's now really knows that people in his state or congressional district are aware of problems. It's very powerful.
And do any that's an important thing, and that was the next question that had come in, actually, is getting the media to take this on as a cause. And so do any others of you want to comment on that, because that is a really important thing. In fact, just last weekend, there was a very high profile story in a Chicago newspaper, and that Friday afternoon we got calls from the congressional offices wanting to talk about these issues. So do any others of you want to talk about using the media or connecting with the media?
I think, this is Toby, I agree it's a really critically important thing to do, telling them about stores and facilities, but sometimes you can write a report, you can do an analysis. It doesn't have to be a 50-page report, it can be a 5-page report about what's going on and give it to the media, and then they will know to talk to you as an expert. That's been effective with a lot of people. It certainly happened in Philadelphia with a very fine legal services attorney, Sam Brooks, who's been writing, looking at the deficiencies and the absence of any kind of enforcement actions, and it got a lot of public attention. And every time there's a story now, I think not every time, but many times he is called as an expert. He's made himself identified to the media as somebody who knows a lot. They do want experts. They always like to have both sides, so they do want to hear if they know who to call. So make it be you, I guess.
Mm-hmm. Great.
This is Rich. This is Rich. I just want.
Go ahead, Richard.
I'm sorry. No, I was just
Go
going to
ahead.
quickly add. As Toby was talking, I was thinking that, as I mentioned before, we put out the assisted living information. Excuse me. Sorry about that. The staffing information on our website every quarter. And you could download that for your state. You could search for nursing homes in your community, and you can let the press know